The title of this talk is going to be on epidemiology of head and neck carcinomas. And so the first question is, why even this topic? And this really has related to the global pandemic that we're looking at, because when we look at the geographic variation of COVID, we can see that it's markedly differs throughout different parts of the world. Initially, there were higher incidence in areas such as China and the United States and South America. Now, unfortunately, much higher incidence in the devastating effects that are happening in India. And when we look at this geographic variation, we decided to look at this large geographic variation of head and neck cancers throughout the world. And this is from the WHO, and this specifically identifies the incidence rates of oropharynx cancers throughout the world. And we can see there's a high incidence of oropharynx cancers in North America, in Brazil, Europe, and Russia, and also Australia. Now, I'll specifically point out the relatively lower incidence in the regions of India, because when we look at the incidence rates of oral cavity cancers, we can see similar incidences in North America, Russia, and Australia, but notice the higher incidence in India, Bangladesh, and Pakistan and Afghanistan, and this is likely due to the use of betel nut. When we look at the incidence rates for laryngeal carcinomas, we can still see high incidence rates in Brazil, Europe, and Russia, but relatively lower rates in the United States and Australia. And this is likely due to the public health efforts to try to reduce smoking and alcohol usage. And what about nasopharyngeal carcinomas? Well, we can see nasopharyngeal carcinomas, there's a higher incidence in Northern Africa and China compared to the rest of the world. So part of this talk is going to be looking at and try to explain the epidemiology and these global variations. Well, this is taken up by the HNSCCA 8th edition. And in the 8th edition, they specifically looked at oncoviruses for head and neck carcinoma. So this really was the focus of our talk, to look at the epidemiology of head and neck carcinomas and specifically focus on the oncovirus. Overall, oncoviruses account for approximately 10% of the global cancer incidence. There are various types of oncoviruses, as I've listed here. We're specifically going to focus on the HPV virus and the Epstein-Barr virus, because the HPV virus is associated with approximately 1 million new cases per year, and the Epstein-Barr virus approximately 200,000 cases per year. When we look at the overall incidence of head and neck cancers, in general, the story is positive. There's a relative reduction in laryngeal carcinomas, again, likely due to the public health initiatives to try to reduce smoking and alcohol abuse. Nasopharyngeal carcinomas also appears to be decreasing. Oral cavity cancers appear to be relatively stable. But when we look at overall pharyngeal carcinomas, this tends to be increasing. And in the HNSCCA 8th edition, they identified a new disease for head and neck carcinomas, and that is the oncovirus-associated HPV oropharyngeal carcinomas versus the standard HPV-negative oropharynx cancers, which was similar to what we'd seen in other editions. So the HNSCCA specifically identified a new disease that's associated with an oncovirus. So when we look at the HPV-positive squamous cell carcinomas, HPV is the most commonly sexually transmitted infection in the United States. There are over 120 subtypes, with HPV 16 and 18 being most common, and HPV 16 comprises about 95% of all HPV-associated head and neck carcinomas. The diagnosis is based on P16 HPV testing. This is the most accurate method to make this diagnosis. However, there's a surrogate way to look at this, and this is P16 staining. Now, this gets a little bit confusing because the P16 is a protein and not specifically related to the HPV 16 subtype. HPV-associated dysplasias overexpress a P16 protein. So on the right-hand side, on the top is a tissue that has no P16 expression, but on the bottom, this is tissue that overexpresses P16, and we can see it's very brown. Overexpression is defined by greater than 75% moderate staining. So the bottom line is that you can diagnose the HPV oncovirus most accurately with the PCR testing. But if you don't have the PCR testing, you can stain for the P16 protein, and this P16 protein is not directly related to the HPV-16 virus. There's two distinct types, again, as I mentioned, of squamous cell carcinoma. The HPV positive tends to affect the tonsil and the base of the tongue, whereas the HPV negative affects all sides. The histology tends to be basiloid for the HPV positive, whereas keratinized for HPV negative. The incidence tends to be in younger patients in HPV positive compared to older patients in HPV negative. The gender ratio is the same. The socioeconomic status tends to be higher in patients that have HPV positive oropharynx cancers, whereas HPV negative patients tend to have a lower socioeconomic status. There is a strong association between sexual behavior and HPV positive, which we'll discuss in the next slide, versus the HPV negative is more commonly associated with alcohol and tobacco abuse. The cofactors for HPV positives are associated with marijuana and immunosuppression, whereas HPV negative tend to be more associated with poor diet and poor hygiene. The incidence of HPV positive oropharynx cancers is increasing, where it's decreasing with HPV negative. Again, this is probably due to the public health initiatives. The fortunate thing is that the survival of HPV positive tumors is improved, whereas it's worse for HPV negative. And when we look at the survival chart, despite this factor, this cancer having an increasing incidence, it does have a better overall survival rate. So when we look at the global variation for HPV positive, notice higher incidences in North America, Europe, and in Australia with relatively low incidences elsewhere. And I remember about a year ago before the pandemic, I had the good fortune to go to the Middle East. And I remember talking about HPV positive squamous cell carcinomas, sometimes a bit of a blank stare because it's so rare in the Middle East. And again, this is identified with that strong global variation. Another paper written in 2015, again, adds a little bit more detail to the global variation. We can see higher incidences of HPV positive tumors in Taiwan. Here's the United States. And then when we look at areas such as Brazil and Spain, very low incidences. Whether this is due to testing, whether it's due to other phenomena, it's not quite clear. But one thing that is clear is that HPV-induced carcinogenesis is associated with sexual behavior. So we would look at the various risk factors. It is associated with greater than 26 vaginal sex partners, greater than 6 oral sex partners. And some people attribute this to the sexual revolution that occurred in the 60s and 70s. So the sexual revolution that occurred about 50 years ago, some people feel that this is the long-lasting effects. There is a vaccination for HPV. The most effective is a 9-valent vaccine because it does specifically target HPV 16 and 18. The vaccine is recommended to be initially given at the age of 11 and 12. The ACIP recommends a vaccination through the age of 26. And if you're between the ages of 24 and 45, it is optional. Now here are a list of other tumors that involve the upper air digestive tract: Burkitt's lymphoma, nasopharyngeal carcinoma, Hodgkin's lymphoma, and T-cell lymphomas. And the thing that these all have in common is that they're associated with the Epstein-Barr virus. Now, the Epstein-Barr virus is a member of the herpes virus family, and it was initially discovered in 1964 by Epstein, Barr, and Achon. It's the first human virus to be associated with carcinogenesis, and it is classified as a group 1 carcinogen. 95% of the population has been exposed, and in most cases, it's usually latent. The first contact with EBV occurs at a younger age, and the replication cycle begins in the oropharynx, affecting the epithelial and B cells of the lymphoid tissues, specifically in the area of Waldeyer's ring. And this is why we tend to see, as we'll see, many of the lymphomas in the head and neck arising in this area. The infection is largely restricted to B lymphocytes, and it's best known for mononucleosis, which are present with enlarged cervical lymph nodes. Now, in 1958, there was a childhood jaw tumor that was first described by Dennis Burkitt. 6 years later, Epstein and his team identified the EBV viral genome in endemic Burkitt's lymphoma, lymphoma, and therefore EBV was felt to be an etiologic agent. Now, it's not just Epstein-Barr virus, but it's also felt that malaria could be an important cofactor. So when we look at the distribution of Burkitt's lymphoma and the higher incidence, notice how it's located in mid to lower Africa compared to Northern Africa, which has a lower incidence. Histologically, this is characterized by the starry sky. I remember some nightmares from medical school about Burkitt's lymphoma and a starry sky or something. I think I remembered it for my exam and then quickly forgot it, but that's the classic example of the starry sky. There are three types of Burkitt's lymphoma: the endemic form, the sporadic, and the immunodeficiency form. 100% of the endemic form of Burkitt's lymphoma is associated with Epstein-Barr virus. This typically arises in children between the ages of 4 and 7, a little bit more common in males, and as mentioned before, high incidence of mandibular involvement, and this tumor can also involve the orbits, as is seen on the right. The sporadic form of Burkitt's lymphoma is associated with Epstein-Barr virus genome in approximately 15 to 20%, whereas the immunodeficiency type is somewhere between 30 and 40%. Now, nasopharyngeal carcinoma is endemic in Southeast Asia, the Middle East, and in North Africa. The etiological factors include the Epstein-Barr virus, early exposures to Cantonese salted fish, smoking, alcohol, and some people feel that there is a genetic predisposition. So if you have a genetic predisposition and then you are exposed to the Epstein-Barr virus, also some of the nitrosamines, smoking and alcohol, then you may be at a greater likelihood of developing nasopharyngeal carcinomas. And in fact, when we look at the incidence of nasopharyngeal carcinomas, we can see a higher incidence of North Africa and China compared to malaria, which is predominantly in the Central and Sub-Saharan Africa. This is the Epstein-Barr virus associated nasopharyngeal carcinoma. Again, higher incidence in Northern Africa and China, and also in the area of Alaska, and this is with the Inuit Indians, which have a higher incidence of Epstein-Barr virus associated nasopharyngeal carcinoma. When we specifically link nasopharyngeal carcinoma, Burkitt's lymphoma with EBV, we can see overall in Africa, high incidence of nasopharyngeal carcinoma, Burkitt's lymphoma. In China, higher incidence of NPC, but lower incidence of Burkitt's. And again, this type of geographic variations is likely due to the environmental exposures that may, and the genetic predisposition that may predispose individuals from getting these two distinct types of cancers, despite the fact that they're both have strong associations with Epstein-Barr virus. Now, for nasopharyngeal carcinomas, there's three subtypes. There's WHO type 1, which is keratinized, WHO type 2, which is non-keratinized, and WHO type 3, which is basaloid. There is a strong association between Epstein-Barr virus and the WHO type 2. So this is the strongest association. And this has now been made its way through the HNSCCA Cancer Manual. And in the new 8th edition, we are specifically now recommending that patients that present with unknown primary carcinomas now be worked up for a specific oncovirus. So if you have someone that comes in with metastatic lymph nodes, as is seen here, in the 7th edition, if it came back squamous cell carcinomas, then it was treated all as the same, as one type of unknown primary. But what's happened now is in the 8th edition, the recommendations now are to test for the oncovirus. And if it's P16 positive, you assume it's oropharynx carcinoma, and you treat the patient as if they had an oropharyngeal carcinoma. The recommendation, especially in areas of high prevalence, is to test for Epstein-Barr virus. If the EBV came back positive, you assume that these lymph nodes are due to nasopharyngeal carcinoma, and the patient should be treated as such. Whereas if it's negative for HPV, P16, and EBV, you assume that this is a quote-unquote true unknown primary, as all of these were in the 7th edition, and the patient should be treated as such. Well, what about Hodgkin's lymphoma? Again, a large global variation in Hodgkin's lymphoma. Epstein-Barr virus DNA and RNA is present in the Reed-Sternberg cells, and these patients also have a high antibody titer. Epstein-Barr virus is felt to have an anti-apoptotic effect, which overrides this induced normal cell death. So it's this anti-apoptotic effect that is felt to predispose patients that have Epstein-Barr virus to develop Hodgkin's lymphoma. And again, I want to point out the absence in Africa and in China of Hodgkin's disease. Again, this probably is related to the associated environmental effects, potentially malaria, potentially the nitrosamines, etc. Hodgkin's lymphoma in the head and neck typically involves the lymph nodes, and we can see multiple examples of lymph nodes both on CT, on ultrasound, and in PET. Non-Hodgkin's lymphoma is also associated with EBV. And approximately 85 to 90% of non-Hodgkin's lymphomas arises in the B lymphocytes. The risk factors are the following. As we mentioned, EBV predominantly finds itself in Wall-Dyer's ring in those B lymphocytes. So therefore, it's not, it sort of makes sense that there is a strong association with non-Hodgkin's lymphoma. Epstein-Barr virus is isolated in approximately 2/3 of AIDS lymphoma. The other risk factors include immunodeficiency, HIV, autoimmune diseases such as Sjogren's disease, and I think we're familiar with the potential parotid lymphoma in patients that have underlying Sjogren's disease, and again, other types of infections, including a couple of viruses, as we see here. The primary sites for non-Hodgkin's lymphoma are lymph nodes, so similar to what we see in Hodgkin's disease, but also Wall-Dyer's ring. And again, I emphasize the fact that the Epstein-Barr virus makes its way into the body and tends to be localized in Wall-Dyer's ring, hence this higher incidence of non-Hodgkin's lymphoma in this area. Non-Hodgkin's lymphoma can also manifest in the orbits and the sinuses, as we're all familiar with. Now, the majority of lymphomas tend to involve the B cells with Epstein-Barr virus association, but there's been recent data suggesting that different types of T cell lymphomas are also have a strong association with Epstein-Barr virus. So the natural killer T cell lymphoma, also known as angiocentric lymphoma, is associated with EBV. Now, when I grew up, we used to call this lethal midline granuloma, but as we've studied this disease more, we now realize that this is a T cell lymphoma, and the current name is angiocentric lymphoma. There is, as I mentioned, a strong Epstein-Barr virus because the majority of these T cell lymphomas do have the Epstein-Barr virus DNA. So in summary, what we've discussed is that we've discussed the epidemiology of head and neck squamous cell carcinomas, and we specifically focused on oncoviruses. There is a large global variation in head and neck carcinomas, as we've seen, and the oncovirus is associated with over 10% of all annual global cancers. In this talk, we specifically focus on HPV and Epstein-Barr virus. This probably explains a lot about the global variations, and they have been recognized by the HNSCCA as specific oncoviruses head and neck. And as I mentioned before, specifically unknown primaries, we now require this specifically be tested for. Thank you very much for your attention.